Now let's jump right into the first session of the day. The pandemic has fueled overwhelming disruptions in the global healthcare ecosystem. Of course, we all know this. Here, the question arises, how will the long-term consequences of COVID-19, the pandemic, reshape the healthcare industry? In fact, everybody in the healthcare industry and not are asking this question. Please join me in welcoming our first keynote speaker for the event, Dr. George Reigeluth, founder and CEO of Prosumer Health, to share his thoughts on the topic, Healthcare Post-COVID, the road from here. Come on up, Doctor.
Let me just add my welcome and congratulations for getting through what has undoubtedly been just a horrific time with COVID. So let me start without further ado. I mean, I feel like this is really a kind of hallelujah moment, if there ever was one, and a huge thanks to IFAH for sticking with this and actually pulling this off. We're going to start spending just a brief amount of time just to sort of set the table on where we are, what's the sort of the landscape that we're in right now, and then spend most of the time talking about some possible new ways forward. And then hopefully there'll be time for some questions and answers at the end. So where have we been? Lots of false dawns. You all know this. There have been a series of interdependent, gradually growing for over several decades, series of problems. Some call them crises in healthcare and healthcare delivery and finance. And it's hard to be overly optimistic sometimes in the healthcare industry because these problems have been going on for so long. The false dawn aspect of this is sometimes during the past 40 years, things have gotten so bad, people have said, well, we can't keep going on like this. It's not sustainable, and something's going to change. And so we see, initiatives put together only to see them fall away for a variety of different reasons. So where are we now? Where are we going to be heading? Is this going to be more of the same in terms of more dysfunction? Or are we at a tipping point, an inflection point of disruption? I think we can all agree that healthcare is, that COVID-19 is and was healthcare's burning platform. Some amazing things came out of this in addition to all the tragedy. And so just, trying to set the stage in a larger context. I'm not going to go through each of these, but if you start over, let's see, I don't want to push the wrong button here. If you start over here with unintegrated care, I think you all know what I'm talking about there, and just go around the circle this way, reading these off. So poor standards for data and analytics, I'm going to talk a little bit about that. Can't actually read my own slide here, sorry. Poor use of data and analytics, preventable medical errors, that's a huge one, clinical burnout, leading to shortages of clinicians, poor access and convenience, systemic racism and health disparities, poor patient engagement in health, poor mental health situation, poor health and care outcomes, poor long-term care. This is the one that nobody wants to talk about, the 800-pound gorilla. The volume-based, crazy volume-based fee-for-service financing system, all of these are leading to higher costs for healthcare. We spend about 2 to 3 times what other people spend per capita in developed countries for care that gives us worse outcomes. You've heard all of this. We now spend $4 trillion a year. That's 20% of a $20 trillion economy. Or to put it in a different context, that's about 30 to 40 cents of every dollar of employee compensation goes to healthcare. My wife is an example of this. She got a pay increase, only to find that her take-home pay was lower than before. Why? Because her healthcare costs went up, the amount that was deducted. So we all know these stories, so I'm not going to dwell on them. The other larger sort of view on what we've been doing is the whole question of social determinants of health. We've been looking, I would argue, in a way through the wrong lens. If you're talking about trying to improve individual health, the concentration on what goes on in the clinic has been somewhat misguided in the sense that what goes on in the clinic only determines about 10 to 20% of an individual's health status or health condition. The other 80 to 90% is what goes on with individual behavior, socioeconomic factors, personal security, individual physiology, and environmental factors. So this is something we're going to talk about as well. So where should we go, great ape? As you can tell, I like dogs. So is this going to be more of the same old status quo? You know, the cynics will say that the entrenched interests of providers and payers, they're not going to stand for too much change as what happened in the past. Or is there another possibility, another future? And our primary premise is that in the last 10 years, there have been a number of significant advances in a number of domains that have made different approaches possible that we're going to talk about. You know about health information technology, remote patient monitoring, artificial intelligence, machine learning systems, smartphones, wearables, et cetera. The next two bullets don't get that much attention, but we would argue just as, if not more important, that is advances in the data, learning, decision, and cognitive sciences. We've learned a lot about how our own cognitive biases and cognitive biases of providers can really affect the way people make decisions, the kind of decisions that they make. And similarly, in behavioral psychology, there's a whole new discipline that's been born in the last few years called behavioral economics, where you use the particular characteristics of an individual to help them find what is their best default position. Example being, instead of a person choosing whether to join a wellness program, even though some of them don't work all that well, that's another question. The default position is that they are automatically enrolled in the wellness program. So lots of little nudges going on here. And our other thesis is that the raison d'etre of what we're trying to do, the overriding objective, everything should be focused on and justified on, will this improve the health outcomes and the health status of our patients, of our employees, of the people we're working with, particularly for underserved families? How can we make them, give them the tools that they need to be healthier? So if health is the objective, care is one of the many inputs into health. As we said, it's not the only one or even the most important. The care team becomes the new health team. The chief medical officer becomes the chief health officer. And I think I'm going to take credit for changing the name of our chief medical officer. I think we were the first company to do this, to a chief health officer, and et cetera. You get the idea. So what if we took all these advances we're talking about and we put them together into one integrated, dynamic, individualized system or platform centered around each of you, each of the patients, each of us as patients. This is a system of interdependent systems like the human body, where all of the systems interact and are dependent on each other and are integrated. Each person would have basically their own individualized healthcare delivery system. Now, I know this sounds outlandish, but I am here to tell you that there are companies out there that have developed and have tested these systems, and they do work. So this is a 24/7 digital device accessible, evidence-based, AI-guided, health coach chaperoned integrated system of resources centered around each person to enable you to find your own best path to health in the context of your particular characteristics and attributes of life, family, work, etc. So the new point of care is out there. It's you, not in the clinic. Sometimes, obviously, it will be in the clinic. So mission is to optimize each person's health and care. We talked about standards. We're going to talk about that a little bit more. This system, tests of this system have shown that users of the system working with a health coach can take care of about 75% of their acute and chronic health issues at higher quality and safety, and that's the key part compared to current best practices, without the intervention of a clinician. Think about that for a minute. That is, even if that's only half true, Admittedly, this was a small sample. It was only about 500 patients. But that's a pretty interesting finding. It's an individualized, holistic approach, comprehensive, integrated, and it resides in a continuous collaborative care model. This whole notion of episodic care is not serving us very well. And our other premise is that if you're able to mobilize and integrate all these forces and resources and put them together so that they're available to me through my smartphone, that you finally give people the agency that they need, the resources that they need to take more personal responsibility, which leads to better engagement and better health outcomes. We've been banging on the table for years saying you should take more personal responsibility for your care. And nobody does because they're too busy. There's too many things going on, and we're not giving them the tools to do this in an efficient way. So where do we start? We start with each other. We start a dialogue, we start a conversation. These guys, I love these guys. Has anybody ever done this, dog sledding? We did this up in Canada. It's a lot of fun. That's a sequel, but an aside. So the evolving new team, which is us, starts with the patient at the center, but the patient's not responsible for driving the whole system, that they are at the table finally. You hear all these talks about patient-centered care at these conferences. I've very, very seldomly seen a patient care representative at the podium when they talk about ACOs being patient-centered and all that kind of thing. Primary care physician is on the team. The health coach is on the team. The system that we were just talking about is on the team. It's making contributions, as I'll show you, in an ongoing manner. Call centers, care managers, public health, community-based social services, community health workers, social workers, pharmacy, behavioral health. I was talking to Jennifer earlier about behavioral health. It's the one that really is the toughest nut to crack. But they need to be at the table. They need to be integrated and in the discussion. So if we are able to create this new team focused on the patient's health outcomes, the team members actually receive training to be a team, which is, people talk about, oh, I'm on this team. They're not really on a team. The health team is built around the patient, who is the center of gravity of the health and care. It's able to integrate primary care, behavioral health, public health, and pharmacy, with the emphasis on social determinants of health. Non-clinical team members, critically important, and taking the care out to the patient. It's not care, it's not clinic bound, as we were saying earlier. You are the new point of care. Parallel efforts, where else do we start? This is a little bit down in the weeds and a little bit, for some, boring and dry, but standards for the quality of the inputs and processes and accounting and auditing are really, really important. This is the very upstream element that has to be in place. Healthcare has only started to work on this problem recently in the last 10 years or so. So ONC and CMS, we're working with them to try to move along the interoperability situation. We'll talk about that in just a minute because there's a double-edged sword there. So this is something, all of these we could spend a whole day talking about. If we're able to put in place these fundamental building blocks of the situation, so the standards for care, the 24/7 digital access to care and health resources, the ongoing support of the health coach, better data analytics, social determinants of health, then we can begin to drop down here, and the health coach can help you put together your health goals and your care plan. You have to have health goals just like anything you're doing. You have, financial planning, you have financial goals and a financial plan. Shared decision-making happens because we're getting task shifting occurring because of the new system is able to take care a lot of the data collection, data recall, data refinement, data vetting, data analysis, guidance, option preparation, and documentation preparation, which used to be done by the clinician, with that task shifting now being handled by the AI analytics system. the clinicians are freed up to do a lot more shared decision making. We'll talk about this in a minute, leading to hopefully less clinician burnout. We've been working with clinician groups on that, and that leads in turn to better engagement and adherence, better care and health outcomes, better care and health decisions around things like diagnosis, labs, tests, images, treatments, and referrals. Who knew that 40% of referrals are incorrect? Similarly, that leads to fewer errors and delays, duplication, fewer adverse events, complications, less morbidity and mortality. We talk glibly about less morbidity and mortality. Remember, those are people who are getting injured or killed because of preventable medical mistakes. Then that in turn drops down to better management of acute diseases, of acute issues, early detection, prevention, and slowing down disease progression. This one, early detection, better early detection and prevention, is one we've kind of given up on, and it really is a powerful factor and force if we can mobilize again with these kinds of systems, have huge impact. Improved management of chronic diseases and health goals achieved more quickly, again, in part because you have health goals, all of which leads to the achieving of the objective of the whole enterprise, which is improving a person's health status, which we have shown is able to reduce the use of traditional healthcare services and related costs, and able to reduce absenteeism, presenteeism, and lost days of school, because all of these problems with rising chronic diseases affect school-age children as well, and therefore their parents, and therefore their productivity at work. And we believe there's a bridge here to value-based payment systems, which we may not get into today, and then that, of course, leads to declined healthcare costs. How am I doing on timing? So then dropping down another level here, you can see over here on the, whoops, sorry, I went the wrong way. On the left are the components of the system. I'm not going to go through all of this, but you see the onboarding data, that process taking place with EMR data coming in, the health coach working to create the health goals and care plan. Then this is the user's problem-oriented health record, which is being fed and is feeding the AI analytics engine, which is in turn connected to the peer-reviewed literature. And then over here you have the remote patient monitoring systems, and down here all of this is in an AWS servers. You have the health coach, community-based social services, and all of this is able to be accessed and run through the system. So the user starts using the system. He's able to, take his daily chronic disease health measures, his infectious disease or COVID-19 surveillance and screening, and risk stratification, readings, RX management, nutrition, fitness, social determinants of health, all of which is being discussed between the health coach and the user in in-app texting on a daily basis. So let's take one example of a remote patient monitoring signal that comes in from somebody's blood glucose monitor, and that reading is, let's say, a little out of the guidelines, is headed in the wrong direction. The AI engine will pick that up and send a set of questions to the user on their smartphone. And the questions come from the literature, not from the doctor. The user answers those questions. Those answers go back to the AI engine, which then analyzes the clinical and health implications of those answers in the context of all the rest of the patient's data, which is a critical component here, obviously, and in the context of the relevant peer-reviewed literature to come up with guidance options on that particular issue. All the guidance options in the data are then sent to the primary care physician, the user, and the health coach, who can, in a smart telehealth call, can do shared decision-making about what's the next step, which guidance option makes the most sense. And then coming on down here, the health coach and the user work together to actually carry that out. You know that adherence and compliance is a huge problem. About 50% of the time, when you get down to here, nothing happens. And so that's a huge voltage drop that we think these kinds of systems can begin to ameliorate. And because you have a health coach who is doing these lots of little nudges with you. And then the community-based social services are helping connect the user to some of the social services in the community that could begin to address some of the social determinants of health, all of which improves these outcomes. I'm not going to go through them all. And underneath all of this is an ongoing documentation, feedback, and learning process for continuous process systems and process improvement, learning best practice for this individual. So we're beginning to approach an N=1 kind of a system. And then this is finally the last layer I'll go down, but you can see here some of the data from these trials that this process results in a reduction in the use of healthcare services by about 60% and the reduction in healthcare costs by about 30%. And I just want to bring your attention to the data dictionary, data language, ontology, and data architecture, a key component underlying this whole system, without which the system couldn't run. Could talk a lot more about that. But why is that important? Well, it's important for lots of reasons, including the ability of the system to adapt to changes. A lot is going on in healthcare right now. A lot of changes are occurring. We've been able to bring in claims data, genetic data, diagnosis tools, all kinds of other new things, including standing up within 4 weeks a COVID surveillance and risk stratification system that people could use to tell whether they were at risk to have COVID or not. And then the behavioral health is here because sometimes we run into a situation where no system can handle everything, where we need to hand off the patient. I was talking to Jennifer earlier about a patient we're working with now who is in an assisted living situation, but she needs to be transferred to a behavioral health clinic for her reasons specific to her that I won't go into. And so this kind of system can help with those kinds of transitions. Just one of the components of the system having to do, going back to that first step, which is collecting all the person's data in one person, one record format. And it's good that the interoperability movement is moving ahead and pushing, but this has been a double-edged sword. For doctors, they're getting hundreds of digital pages that they have to leaf through. It's adding to clinician burden. And so our approach to this, and in addition, the problem is once you get all the data in one place, it comes in vertical stacks of data for labs, tests, images, treatments, and it doesn't tell the story of the patient, of what's actually going on and what is needed. In order to address that problem, there is an approach called the problem-oriented health record, which organizes the data by the problem. So this particular individual has epilepsy, and you see the meds, labs, imaging, procedures, clinical notes, hospitalizations. They've all been pulled out of those vertical stacks and put together under epilepsy, so you can see what actually happened to this person with respect to their epilepsy care, are there care gaps, et cetera. So this is a big deal, is to get this figured out and get it done. And ONC is viewing this favorably, this whole idea. So what do you think? Does this make sense? Does this new approach make sense? Is it going to work? We've shown you some data that suggests that it does work in some cases. The remote patient monitoring is really going after the low-hanging fruit. So we've gotten some amazing numbers with this, where it reduces inpatient days by 57%, the use of, remote patient monitoring devices at the home and in the office, reduces readmissions by 54%, reduces home health visits, trips to the ER, increases care plan adherence, and reduces infection risk, and frees up hospital space and clinician time. So we think that There is something interesting here. It's early days. This is a heavy lift, but we do see progress on the standards. We do believe this new division of labor with the patients and the analytics engine and the health coaches being the three new healthcare primary care providers, if you will. The team is facilitated by the data analytics. Everybody's on the same page. I was talking to one multidisciplinary team out in the Pittsburgh area that is looking at this kind of a system to begin to unify them around, well, this is the data set that we're using. It is a complete data set, includes social determinants of health. Patients establish their own health goals, and we talked about that. There is a bridge to the value-based payment system, which we can talk about if we have time. The holistic wellness, early detection, prevention, and integrated connected care and health, one person, one record. Everyone owns their own data and has access to a health coach. What would happen if low-income people were given access to and were able to own their own individualized healthcare system? That might be interesting. So I'm going to stop here and just say that this is, as I said, early days. It's a heavy lift. We hope to hear back from you, start a conversation. If you're interested in this, we'd love to continue talking with you about that. And thank you very much for your attention.
This is the next step you should take. What ends up happening is that actually getting that done and getting through the system becomes impossibly complex. And mostly I'm talking to people who are well-educated, who are working in the aging space, and so I don't know what it's like for people who are outside that. How do we solve that human problem?
Our response to that is first the health coach. Okay. Can you hear me now? Okay. So as I mentioned, our response is first this new healthcare team, on which you have your individual, the patient, you have the health coach, and you have the system. Don't downplay the importance of the system in feeding advice and guidance options. It's looking all the time and analyzing new data that's coming in. So the health coach is really key in this. I'm working with somebody who I mentioned who's being transitioned from a assisted living environment to a behavioral health environment, and it's very hard and I've got all the latest stuff, and we're driving around looking at different facilities, and I'm basically acting as her health coach, and it has to be able to be paid for by Medicaid. She has to fill out an application to qualify for Medicaid. I mean, I could go on. So if you're able to enlist those services plus the community-based social services, and they are all playing on the same system, our thesis is that while I debated whether to go down into the weeds and show the complication, I wanted to show the complication because it's not easy to put this together. But once you put it together, to the user, they don't see any of that. They see questions about their cough that are sent to them by the AI analytics engine, and then the system takes care of the rest. It analyzes it and produces the guidance options, and then you can have that discussion with, in your case, with senior care, it would be an advocate like me for this person. So I think there are new models out there, and we need to start using them. I would be lost without this person's, health, problem-oriented health record. And so, as I say, it's early days, but would love to continue the discussion. Anybody else? Sprung up that are specializing just on being a buddy for somebody, because social isolation and being lonely is a huge problem, particularly among this gentleman's cohort, the elderly. And so they have a system where they get in touch with the individual, and then a person from the community comes over and plays cards with them or whatever, takes them on a walk. During COVID, that was a little difficult, but they found out ways around that. And the reimbursement angle of this is pretty interesting, because CMS is starting to reimburse for things like care management services, for onboarding services, for remote patient monitoring devices, for the actual cost of the remote patient monitoring device. If the doctor is able to get the patient to use the remote patient monitoring equipment so many times a week or so many times a month, then they will get reimbursed. So the doctor's financial interest and the patient's health interest, for the first time that I know of in the US, are aligned. And that's pretty exciting. So yeah, a lot of good stuff. I mean, a lot of other countries, Europe, I lived in Belgium for 15 years, and there are a lot of things we can learn from other countries. Yeah.
Actually, I saw this underlying process. Oh, thank you. Hello? Yeah. Now it's working. Sorry about that.
On the podium, because there will be a feedback because you're really close to his mic.
Okay.
Yeah, so I saw this underlying causes for the dysfunction, and we think that these are very important. But also one important point is missing, that what we feel is non-compliance, because all the patients are not getting their medications in time, so they are ultimately getting back to the hospital and to the physician's office, and it is costing more money to the entire system, basically.
Yeah.
So is it, do you think that is also important, one of the function that should be part of your presentation? Or do you think it is also important or not?
Yeah, no, non-compliance, non-adherence is huge. I mentioned that at the end of this process, where you have the guidance options and the health coach and the individual, the user and the primary care physician deciding in shared decision-making, all right, we're going to go with guidance option A. 50% of the time, what is decided upon never happens. Medications are not picked up, x-rays are not taken, the visit to the doctor is never done. So the way we think, one of the ways to help address that problem, to mitigate it, is through lots of little nudges, lots of little reminders that this is not a big deal. This is me as your health coach texting you and saying, I'm sorry, what's your name?
I'm sorry.
What's your name?
Hemant Shah.
Hemet.
Mr. Shah.
Yeah, Mr. Shaw, I see that you didn't take your medication today, because your pill pack will show that you didn't take your medication today. But before that happens, the pill pack will beep once in your house. If nothing happens, an hour later, it'll beep again. If nothing happens after that, then me, your health coach, will send you a message and say, so there's a lot of work going into this problem because it's huge.
Well, that is a good, I know the pill pack, the company, but what we have done, we have created a digital platform where we deliver medicine to the patient home within a matter of hours.
Yes.
On the same day, as soon as they request it. So this is a platform that we created that focuses on all the patients, all the pharmacies, all the hospitals and clinics. So we are not married to anybody else, we are just married to the patient-centric. So I thought about that. This is also very important
we need
kind of a component.
We need to talk, because we have a system that does this, delivers to the house, but it's not for all pharmacies, so.
Thank you. We can
Thank
meet.
you.
This is check.
Yeah.
Can you hear me? Okay. Fantastic presentation. Thank you. That's a lot of very comprehensive information. Obviously, the healthcare system is complex and broken. I think that's obvious. But what I'm wondering is there a company or organizations that you can cite as examples that have made tangible progress in this, that have been able to successfully integrate all of this data and provide a standardization of all the key processes around what's involved here? Thank you.
Gee, I wish you hadn't asked that question, because my company, Prosumer Health, is. No, I don't want to talk about my company but yes, there are a number of companies that have put together variations of the platform I'm talking about, and I'd be glad to share that information with you and the other conference attendees. This is not a gleam in somebody's eye that I'm talking about. I would not have come here if we're not able to talk about something that has at least been tried in a number of cases in a number of different settings on real patients, because then we're just talking about blue sky. This is not a gleam in somebody's eye. This actually works.
So I'm a counselor, and I've historically worked with a chronically ill population, and so I really see the benefit of having all of the patient information in one location. I've worked with patients who their pulmonologist is not communicating with their primary care physician, is not communicating with their psychiatrist, is not communicating with their counselor, and I essentially become the person who's coordinating the care for all of these, prescribers and clinicians, because I'm seeing the client an hour a week, whereas they're seeing the patient 30 minutes every 3 months. So I see the benefit of this. And my question is, as the mental health professional, would your recommendation be that our treatment plans and progress notes also be uploaded into such a system so that other clinicians can also see what's going on as far as their emotional and mental well-being?
Yeah, our feeling is that everything that is involving the patient should be on that one person, one record. And people ask, well, why do you need, dental records? Well, it turns out that dental records and vision records are important, because things that go wrong with your eyes and your teeth can be advanced indicators for things like periodontal disease is an advanced risk factor for type 2 diabetes, et cetera, et cetera, et cetera. And so we're missing all these opportunities because the data is not there to pick up on early detection and early intervention and prevention. And that's why I was underlining that those two as really where there's huge potential if we are able to to do that.
Hi. Great presentation. Thank you. My company works in medical tourism. We work in Mexico. We treat patients normally from the States or Canada. We do treat patients from other countries, but mostly the U.S. Have you tried or have any company tried to integrate this on an international level? Because there are millions of people flocking from the States because of the issues that you mentioned in the healthcare industry here. So have you considered expanded to other countries? Normally, just sharing information because of HIPAA compelling platforms, everything, it's quite difficult for providers in other countries.
Yeah, so we are talking to people in England because I was in Europe. I have pretty good contacts with most of the major European health centers. India, we're talking to some people in India, Argentina. I think there was somebody from Argentina here. So yeah, I mean, this is not a U.S. problem. This is a global problem. One approach that I'm very interested in is going directly to the consumer, in the community, and that's one of the approaches we're trying in India. You're not trying to bypass the central health authority, but you can make some progress working on a small scale with a particular community and that local community health center. And why not take it directly to the consumers?
Yeah, there are platforms, for example, in the, when you're talking with human resources or platform working with the human resources managers for corporate wellness that are similar in a way that they integrate the information of the worker but they do it in a very small scale. And we do work with some platforms like that. But you're right. I mean, the major problem is to have the providers in every single city.
Yeah, we work quite a bit with wellness programs, and I don't want to denigrate them because a lot of good people are doing a lot of good things in them. But there's a whole discussion about wellness programs that needs to take place.
Guys, we have time for just one more question if there's anyone. Okay, our last one, right? Oh, okay. Maybe we'll do
Thanks.
2 quickies.
I've worked as a registered dietitian. I've worked as a health coach. I see the need for integrative wellness in a variety of ways. One of the things that has frustrated me and I think is still in the conversation needs to be brought up is the importance of understanding the patient's, client's readiness for change. Every professional can tell you that you need to change, you need to improve your diabetes numbers, you need to improve this, you need to improve that. If the client doesn't have a readiness for change and nobody has talked with them about the understanding of the readiness for change, that's where the non-compliance comes from.
Right.
And so from an empowerment of a health coach standpoint, the health coach then becomes a nag. They become the person that is not seen as an advocate for you anymore because they are seen as the bad guy who's reinforcing what the doctor has told you need to do. Yeah. So the one thing I would say in this dialogue has to be the backing up of understanding that we might say that the client needs to have a blood sugar of 100, but if the client is at 200, let's agree on 150. Let's look for what the client is really willing to do instead of looking for the perfect.
Right.
And let the health coach be the advocate and not the bad guy.
Right.
Where do you see that in the dialogue? Where do you see that movement to?
What's your name?
Tanya.
Tanya?
Tanya.
Tanya. So thank you for bringing that up. One of the things, I have to leave out a lot of things in this presentation. One of the points that needs to be made right up front is that the health coach is, when the health coach is introduced to the patient is asked, do you want to participate in this program? It's explained to the person, and the patient will either say yes or no. If they say no, there will be an additional outreach to try to help them understand what it's all about. For those that say yes, the idea with the health coach, as you know, is for over time, and not all at once, to build a trusted relationship with that person. It's amazing what happens with complete strangers, a health coach. People will feel a lot more comfortable telling you about a really serious issue that they don't want their family to know about or whatever. And so that is a really important part of that. Having said that, there are some patients who just are not ready to do this.
Right.
And you can do all the best stuff in the world.
Right.
And no, I don't want to play ball. And
As a health coach, I don't want somebody that's a 2 on the
Right.
scale of
Right.
readiness to change.
Yeah.
I want the 3 maybe, but I definitely want the 4.
Yeah.
And so if we're not doing that assessment up front, then everybody's knocking their head against a wall.
Exactly.
So
No,
that's great to know that
my
that's
next door
part of it.
neighbor. My next door neighbor is like this. I was having dinner with them, and I was explaining, my program and how I was all so proud of it. And Karen looked at me and said, "Why would I want to do that?"
Right.
And
They're
so
a 2. I don't want them.
There are a lot of people like that. So go with the people that are, and there are plenty of them out there.
Right. Great. Thank you.
Awesome, guys. We have time for just one more quick question, and then we're going to move on. I think it was the gentleman right here.
My name is Justin. I'm from Montana. I'm a dog lover as well. I helped create a company that works with direct primary care. Are you familiar with the direct primary care model?
Yep.
So we moved away from fee-for-service and did a monthly periodic fee. And part of that, we redefined what primary care was. And what we did is we included pharmacy, physical therapy, mental health, health coaches, and imaging within $125 a month was the membership fee. One of the biggest things was that we found is people it's too new, it's too different, they don't understand it. And part of that was breaking down the barriers and the silos between the disciplines. When you're talking about the change in the medical industry, probably the biggest thing that we've seen is moving away from fee-for-service and going to that value-based care.
Yeah.
And I represent the physical therapy industry. This company I'm out of at this point. But how do you see, with all these different changes, that seems to be the biggest one that people are dependent to. And you see CMS trying to make those changes.
Yeah.
I guess the biggest question is, how do you see moving away from fee-for-service into a value-based care? And then maybe also, what is your experience with DPC? And do you see that being a viable option as well?
Yeah, so thank you for that. So I mentioned in the talk a couple of times that we do see these kinds of systems as a possible bridge from fee-for-service to value-based payments in the following sense, that the biggest problem we find in talking to care teams at community health centers or other primary care offices is fear on the part of clinicians, because they don't have the tools to actually improve the health outcomes of their patients. And if they can't improve the health outcomes of their patients, they're not going to be able to qualify in a value-based payment system. So we spend quite a bit of time up front doing what we call sort of planning work, which brings people together. And there's a lot of fear out there about change. And is my ox going to get gored? Is my job going to change? We are talking about changing job functions and changing job descriptions, and doctors not doing some of these tasks because they don't do them very well. It's not because they're bad people. It's because we're human beings and we don't do data recall, data analysis, all of that as well as systems do. So let's offload all of that. But you have to go through that discussion. And then if you're able to actually get them to start using the tools, there's a wonderful account of this that I can send you of a doctor who in Sioux Falls, Iowa, I think it was. And he realized that this was the way to go when he realized that his medical assistant who was acting as the early version of the health coach, knew more about his patients than he did. And the medical assistant and the coach, the medical assistant and the doctor and the system were actually improving health outcomes, reducing the use of his traditional services, and reducing his fee-for-service billings. Well, that qualifies him for participation in the shared savings benefit payments from value-based payment programs. So that's the way we see that this can be a driver for value-based payment systems.